I recently got back from the largest hair restoration conference in the world, this time held in Denver, Colorado. Yeehaw! And here are some of my takeaways, divided into three main sections: medical therapy, surgery, and my thoughts on some of the other hair doctors that I met there. When it comes to medical therapy, oral minoxidil is still all the rage. It's a very popular choice of medical therapy for hair restoration to thicken your hair, and we talk a lot about it on this channel. I normally prescribe 2.5 milligrams as a starting dose for men and 1.25 milligrams as my starting dose for women. But some are now prescribing higher doses of like 5 to 10 milligrams daily. And early studies are showing that it might be just as safe and even more effective than the lower doses. As the dose of oral minoxidil goes up, so too do its potential benefits of improving your hair. But based on the literature that I've reviewed before some of these newer studies that are coming out, there is some concern for higher risks as the dose goes up. And remember that oral minoxidil was originally used for high blood pressure, so some of the side effects that are possible include low blood pressure, palpitations, headaches, or even effusions that can manifest as leg swelling, but also can present as fluid around the lungs or the heart, called pleural effusion or cardiac effusions. Generally, oral minoxidil at the doses that I prescribe is extremely well tolerated with very rare side effects. But as we start to raise the dose, I am concerned that more people might start to present with some of these other cardiac complications, and we have to weigh those potential complications with the fact that this is still a medication being used primarily for aesthetic gain. And remember that minoxidil is not the drug of choice for preventing further hair loss. It serves instead to mainly stimulate hair growth, and we have an entire video on oral minoxidil, so make sure to check that out. Another medication that got a lot of attention at the meeting was topical finasteride. Its use is on the rise, and many people no longer want to take oral finasteride because of the concern for systemic side effects, and instead are opting to go with a topical finasteride solution. And we do have a version of topical finasteride, so make sure to check that out if you're interested in learning more. But there are many formulations of topical finasteride with very few head-to-head comparison studies. So I think more research is needed to help figure out if one formulation is better than another. There was one speaker who raised a good point that the spray form of topical finasteride may not penetrate the scalp well enough and may not be absorbed as well as the solution form, for example, which is also why I prefer the solution over the spray. And I know that people are getting very excited about topical finasteride, but I think that we need to keep in mind that it may not always suppress DHT levels enough to reduce hair loss, which is really why people are taking it in the first place. And the other thing to remember is that it could be quite toxic during pregnancy in its potential to cause toxicity to a male fetus. So men need to be extra careful when applying topical finasteride around women who are pregnant or may become pregnant. And we also need to remember that high enough concentrations of topical finasteride can tank DHT levels below the levels that we see with oral finasteride, which would defeat the purpose of being on topical finasteride in the first place. Most concentrations of topical finasteride that have been tested in the literature are in the 0.25 to 1% range, but some companies have concentrations as high as 2.5%. So if we're applying those types of concentrations on our scalp, especially if the quantity is sufficient, we might drop our serum DHT levels lower than the levels they would reach with the standard dose of oral finasteride alone. So please be careful with A, the concentration of topical finasteride that you're on, B, how much of it you're applying to your scalp, and C, how often you're applying the medication. And when it comes to medical therapy for hair restoration, we're usually putting people on these medications indefinitely for them to maintain their hair. But one team in India is using a pulse dose medical therapy regimen. So they're not using these medications throughout the year. Instead, they have most of their patients on 6 months of oral medications, followed by tapering patients off of the oral medications for 2 months, and then using the topical formulations for another several months. And then they restart the treatment cycle at the 12-month mark. Maybe this is adequate to maintain the gains from medical therapy, but it's still unclear and more research is needed. Now, the next topic I wanted to discuss when it comes to medical therapy is synthetic peptides, ones that are made in the lab and not animal derived. Various proprietary blends of these strings of amino acids are on the rise, and most of the data is in vitro, showing various elevations of proteins and growth factors that have been shown to have some implication on hair growth. But there are not many clinical studies that are actually published, and synthetic peptides are not FDA approved for hair restoration. So they're marketed as topical cosmetic use only compounds. But some people are actually injecting these peptides, just like some people are injecting exosomes. It really is the wild, wild west out there, so please be careful. There are also some new drugs on the horizon that I wanted to highlight here. Let's start with the topical medications. The first class of medication are androgen receptor antagonists. These compete with androgens, specifically DHT, for binding to the androgen receptor. These include clascoterone, which is currently FDA approved for acne, and pyrrolutamide, or KX826. The next medication is actually an androgen receptor degrader. It's called GT20029, and it reduces the cell's ability to respond to androgens like DHT. This approach could provide a more complete suppression of androgen effects in specific tissues, and all of these medications so far show limited systemic absorption. So hopefully they'll limit the actual side effects that we feel, and they'll enhance some of the local effects that we're looking for, such as reduced hair loss and more hair gain. Another new drug on the horizon that's not topically applied, but rather as an injection, is called HMI-115. This is a monoclonal antibody that targets prolactin receptors. It's administered systemically via injections. Systemic administration allows it to block these receptors throughout the body, including in the hair follicles where prolactin signaling may contribute to hair loss. But remember, this one does have systemic absorption, so potentially people could see worse side effects, but we'll see what the studies end up showing. We definitely need more robust clinical research when it comes to hair restoration, and I'm hoping to do more of it in the years to come. I did enjoy this one non-surgical PRP project that we had for the jet peel system, where we were looking at a needleless way to administer PRP into the scalp, and we published a pilot study a few years ago. We'll link to that here if you're interested in reading more about it. And I even got on TV to discuss those findings. Now let's talk about some of the surgical takeaways. The first is that I feel like there's no consensus still on the ideal FUE punch that's used for harvesting hair. Referring to the outer diameter of the punch, there's still a broad range of what surgeons use for harvesting scalp grafts. It could be anywhere from 0.7 millimeters up to like 1.3 millimeters, or even larger. A larger punch can yield a higher coefficient, and a coefficient refers to the average number of hairs per graft. But a larger punch will also leave behind larger scars. Smaller punches reduce the coefficient, leading to lower final density, but smaller scars. Another variable here is the actual punch design. That can also affect the final scar size. So a 0.95 millimeter punch with the WA system that I use could leave behind a very different looking scar than a 0.95 punch from, say, like the Ella system or some other system out there. And then of course transection rate plays a big role here as well. So if you're looking to harvest 1,000 grafts and you keep the transection close to 0, then you should have close to 1,000 holes on the back of the head. But if your transection rate is rather high, to get 1,000 grafts you might need to punch out 1,100, 1,200, 1,300 or more holes to get the same number of grafts. So it's not just the punch size that leads to the final scarring appearance, it's how low you can keep that transection rate as you harvest. Now let's talk about some of the new technologies that were discussed at the meeting. The first is used for surgical planning. It's called scalpscan.ai, and it was developed in part by my good friend Dr. Felipe Patella in Brazil. This app gives you the graft number prediction related to the number of grafts that you have to give from the donor area and the number of grafts that you may need in the recipient zone. One of the disadvantages, in my opinion, is that you need to shave the donor area to be able to get this type of prediction. But this is the case with most hair detection tools. Also, the app calculates the prediction of graft number needed at a density of 50 grafts per centimeter squared. But many people would be happy with a lower density. And just because the app tells you that you need 10,000 grafts doesn't mean that the person actually needs 10,000 grafts to be happy with their outcome. First off, they may not want to spend the money for 10,000 grafts, and they may not want to deplete their donor area to get that type of number. Another new device used for implantation of hair comes from N-Graft Technologies. This was developed in part by my friend Dr. Bill Rossman, and I have a podcast video with Dr. Rossman that I hope you all check out. This device is intended to help with improving the speed of implantation and also reducing the manipulation of grafts to help improve survival. Some of the disadvantages that I see are that we need more clinical data. This isn't a tech that's available for purchase just yet, but hopefully in as early as 6 to 9 months from now, they'll have more clinical data so we can see that graft survival is very high, and we can also try to figure out if we can use 3 and 4 hair grafts with this device and if it will work for curly hair. The next tech I wanted to talk about is in the realm of AI and robotics. Several companies are working on technology that would allow us to simultaneously harvest hair and implant it at almost the same exact time, potentially without much human intervention. I do have some concerns around this type of technology because I wonder if it's going to reduce the artistic beauty of what a hair transplant can look like, and if it will look a little bit more robotic or just not as unique and personalized to the individual. Now, it might look great, so time will tell, but that is a concern that I have. And also, with the simultaneous moving of the graft from one location to another, what about the times that we need to create single hair grafts to, for example, work at the hairline, right? So we have a nice natural look, or when we need to trim down the grafts so that there's a little less skin on the grafts from when we go to place them. Those steps definitely consume more time, but I think they're the right thing to do to optimize the outcome. If we're just worried about the speed of transfer, I think we might be missing the big picture, which is that we want the final outcome to be as aesthetically pleasing as possible. And at this time, at least, we definitely still have a lot of human presence when it comes to hair transplants. So my friend Dr. Max Schumacher has an interesting solution to reducing fatigue on the surgeon, and that's to wear an exoskeleton type of device to reduce the load on the back, on the arms, and to overall improve our ergonomics during surgery. I thought that was a very clever idea, and one that, who knows, maybe I'll try out. Remember, hair transplants are long procedures, and if we can reduce surgeon fatigue, I think that's a very good idea. So thank you to all the people who presented at this ISHRS conference and for pushing the boundaries on hair research from basic science to the bedside, and to those sharing their clinical experiences with the group. And thank you to those who are working on these new technologies to help us do better, more efficient hair surgery. And I also wanted to thank those doctors who came up to me from all around the world and acknowledged our YouTube community and told me really nice things. And they said, hey, I don't have anywhere to learn some of these different procedures or concepts, and I have used your videos as a resource. That of course made me feel great, and it was really cool to talk to these folks and take pictures with them, and that was great. So I very much appreciate it. But again, I can't take all the credit. I have an amazing team, and it's all of you watching that make this channel possible. So thank you all. It was amazing seeing my friends from all around the world who do incredible hair restoration work, many of whom were at the WFI meeting that I was at earlier this year in Morocco that I also created a video about. If you haven't watched that video, make sure to check that one out next. But being able to hang out with the same group from again around the world was super fun, and I'm sure I'll be bumping into them in many meetings to come. These are some of the kindest, most talented and passionate people that I know in the hair world. And I did get to meet some of the big wigs in the hair restoration field. You may not see some of them online, but they wield a whole lot of internal influence. And I know that some of them think that I just make these silly videos. But I think that if they spent some time truly listening to the messages within my videos, they would start to see some of the overarching themes that are within, including educating patients, colleagues, and most importantly, keeping our patients safe. I hope to continue to work with them to blend the classic style of educating with more modern day approaches. I think there's a lot of potential synergy between what I do online and what they do in less digital form. We must all come together and raise the bar on providing safe and aesthetically sound hair surgery for patients around the world. Thank you and see you soon.